Well, I'd like to introduce Richard Millard, who doesn't really require an introduction, but is Professor of Urology in Sydney and who worked at the Middlesex Hospital years ago and was one of the three co-chair people at the session on overactive bladder and its definitions at the ICS meeting in Beijing. The three co-chairs were all out of the Middlesex stable as a matter of interest, where Richard Turner Warwick, who was the chief, had an emphasis on terminology and getting it straight so that everyone knew what they were saying. This was a tribute to Norman Zinner, who died earlier this year, Richard, and how did you feel that session went, that overall?
I think, in fact, it was most instructive because we had one of the originators of the term overactive bladder in Alan Ween telling us about the good, the bad and the ugly, and the things that he realises should now be changed as a result of 10 years of clinical experience and use of the term. Marcus Drake, I thought, gave a very good presentation on how important consciousness is to not only our perception of overactive bladder, but also to what we do about it. How some people, and the majority of people with an overactive bladder, actually turn out not to get wet, whilst 37% of them do get wet, and what we might do about that. I think there's a lot we have to learn, not only about the terminology, but also about the treatment. And that was something that came out particularly in some of the presentations, that we're quite a long way from being able to sort out what is the best treatment for the individual. We have all sorts of treatments which are, what I might say, blunderbuss treatments, which aren't very good, and only a few that really will change and revolutionise people's symptomatology. Because from my point of view, and I'm sure from your patient's point of view and my patient's point of view, if you're wet, what you want to be more than anything is to be dry. And that is the next leap forward that we have to do, because I think our treatments are falling way behind what we can perceive, not only from the symptoms of the patient, but also from the urodynamics. Is that how you saw it?
Yes, I did. And I think to try and clarify these things is so important, because we're all talking at slightly different meanings and emphasis. And the distinction between those who've got OAB dry and those who've got OAB wet may be artificial, or they may be emerging of the various causes. If a person has urge incontinence, by definition they must have had a detrusor overactive contraction or an uninhibited relaxation of the urethra. So in a sense they can be diagnosed to a degree from the history, whereas those that have got the OAB dry are not so easy to sort out. What do you feel about that?
Well, as I say, I think the urgency that we are dealing with is urgency for fear of leakage. And it's that fear element which came out in both Werner Schaefer's presentation on the urodynamics in OAB, and in Marcus Drake's presentation of our conscious awareness, and how all of a sudden something changes from being in the background to be in the forefront of our minds, when all of a sudden we think we're going to wet our pants, especially if it's in front of an audience.
One of the other speakers today was Kari Tikkanen,
Yes.
who is an epidemiologist in McMaster's, and originally came from Finland.
Yes.
And he spoke very well on the epidemiology and the difficulties in considering OAB as a diagnosis, which he emphasised it isn't. It's not a diagnosis, it's just a group of symptoms. And that to me was a really important thing, which was emphasised also by Derek and other speakers.
Yes. Yes. So it's a term which, at its broadest, helps us to communicate with our patients, and if they can understand it, then it should continue to be used as such. What we use it as scientifically, however, is a completely different cup of tea. And yes, I agree with you that if you're going to wet your pants, it's got to be that either the sphincter is relaxed or that the bladder is contracted, or both.
Yes.
And that's what it brought up. It made us question what we mean by what we talk about. Our task as physicians is to sort out what is going to be the best treatment for the individual and change their lives for the better forever.